Well, good morning, everybody. Happy Saturday, and welcome to the last half day of CVI, and it's been a wonderful week. Thank you so much for being here. I have the pleasure of being a moderator here and sharing this with Hemal, Gada and Mark Gajjar. And our first speaker is Kashish Goel. So this is a Hail Mary symposium, so let's see what turns up here.
Thank you. Thanks, Paul, again for the invitation, and happy early morning. I think we are all jaded from last night. So let's start with this case. These are my disclosures. So this is an email that I got from the patient's daughter. My name is this. So my grandfather was recently diagnosed with aortic valve stenosis. We have been researching TAVR, came across Vanderbilt as a possible choice. We live in Kentucky, about 3 hours from us. So Vanderbilt is about 2 hours from them. Recently hospitalized, fluid buildup, IV diuretics, rushed back to ER tonight with chest pain, trouble breathing. I'm contacting to see you if there's any way we have him transferred to Vanderbilt from our local hospital, bypass his current doctor. They've been dragging their feet to getting him a referral, and we're trying to see if we can see a new doctor for his surgery. Whole family feels like he's running out of time, and we are pulling every strand that we can. He's in great health otherwise. If you have any information that may help us, please let me know. This is my email, this is my cell phone. I appreciate you taking the time. So this is how this started, and we actually brought the patient almost next day to our clinic. We got a CT scan, but this is a history. He's 83 years old, history of CABG, actually has low EF for about 5 years, and now has severe low flow, low grade aortic stenosis. This is his mean gradient, and he has pulmonary hypertension, left bundle. So after seeing him in clinic, we got a CTA same day and actually admitted him to the hospital after the CT. And now his repeat echo, so the previous echo was only a month old. So now his repeat echo EF was only 10 to 15%. He still has obviously severe AS. And he was initially admitted to step down, and actually, I remember this was Saturday morning, one of our brilliant heart failure cardiologists was rounding, and she called me. She said he had a syncopal episode this morning. I think he's in a low flow state. We need to do something today. So he goes for urgent right heart cath with one of my partners. And these are his numbers. As you can see, severe pulmonary hypertension, wedge of 42, and it actually correlates with his diastolic PA, so it was actually pretty high. And index was 1.4. At that time, actually, because of his decompensated state, the decision was just made to place an Impella CP in the cath lab. This was, again, I think, an urgent decision made at that time that the patient was just in a very, very low flow state. Just to show his measurements, because we had it at that time, because he had the CT a couple of days prior, and you can see his annulus area was 622, good sinuses, STJ about 26 to 29, and pretty heavily calcified valve.
So how did you get the Impella in? You just shoved it in there through the...
So they did not do a BAV. It was done actually by one of my interventional colleagues who doesn't do structural. and he was able to do that without any issues.
But even, the IFU is 0.6 centimeters squared. So even in the IFU. And I've done as small as 0.4 without a BAV.
I've done it too. I've done it up to 0.4, 0.5.
Yeah.
Without a BAV.
Without a BAV. Yeah.
And it actually bypasses the flow.
Yeah.
And then you can actually, the patient stabilizes.
But Mark, you know how to BAV. Why wouldn't you just BAV? Because you're plugging this hole, and then it's an Impella as a bridge to what?
Because
that's the clinical
few
challenge.
months I'm on a podium, and I have to say that I did something. No, I mean, the BAV is, if you don't need the BAV, and like you said, it gets rid of the AS in a way. So...
Mark, that's your question. That's the challenge. What do we do?
There you go. Yeah.
Here are the options. Would you do an urgent TAVR with one of the valves, keep the Impella, or what you said, do a BAV in Impella, or do an Impella in stage TAVR, or this is just too late? This
I don't know. You had to treat the pathology in some way. I don't think I'd be game for TAVRing at this time, but I would definitely would BAV. So whatever strategy we're going to use for the support and the recovery is, I think, an ancillary issue versus treating the actual pathology. So yeah, I would Impella plus BAV.
And I think the other question is, are you trying to get this person a little better before they come back for their valve, or are you planning, it's Saturday, we're doing it Monday type of thing? I think that would be.
That's the question as well. I think it's a Saturday, but then
and
BAV.
that's a really good question, I think, as well. And I think that, having that time to think that decision over is bought by the Impella plus BAV strategy. I don't think you need to commit to that strategy right off the bat.
Do you know if there was aortic regurgitation?
Very minimal.
So, sorry, I was gathering microphones, so I missed a little bit of this.
You want me to go back to the case?
But no. But I get the sense that some people want to do balloon, and you're debating whether or not to do TAVR now.
No, I think the question was, so the first was like, direct Impella, like at the moment. One of his non-structural colleagues, brought the patient to the cath lab, put an Impella in, didn't BAV.
I see.
Yeah, exactly.
So we would consider BAV, but honestly, we would just do the TAVR. So the way we often do this at our hospital is if somebody is crumping or in shock, which sounds like this guy is really just
His index was
crumping.
1.4.
He's likely under anesthesia, I suspect.
He was actually on the floor and had
Okay.
syncope, but he was still actually conscious sedation for now.
He's probably on his way to
he's on his
getting
way.
intubated. And so we would just intubate the patient. We do 3D sizing for the aortic valve. We do IVUS for the periphery, and we just do your valve of choice. If he
Without
has time
CT
to
or
get
anything?
no CT. If he has time to get a CT, then of course that's helpful. But oftentimes if they're crumping, we just if we're going to do a BAV, we just do the TAVR because Mark was asking about AR. If you get an AR, your
That is my concern with
Impella's not going to
BAV.
work very well if you have torrential AR. So
Hemal does a lot of BAVs, but
My practice is exactly the opposite of yours. So,
and that's why we get along.
What a shock. I'm with Hemal on this one. And I swear yesterday you did a BAV on a transcatheter heart
but
valve.
he doesn't
It
know
is.
the balloons that he's using even. He called like it was obviously a CVI balloon. He said it was a true balloon.
And being practical, in 2025, we are measured by our outcomes.
Agreed.
And to throw in a TAVR valve, and look, TAVR is the right answer. But we all know in an ideal situation you do a TAVR. But we are measured on our outcomes of mortality,
But there's
AKI,
a-
bleeding.
in the TVT registry, which Kashish knows very well, there's a box that you check. It's called salvage. And you check the salvage box because this guy is a salvage case. And it's okay for your outcomes because it's a salvage case.
Does it negate the negative outcomes completely?
Well, you're trying to save this guy's life.
You're right now it doesn't, and I think that is an important point though. In TAVR TVT reporting, your mortality is still reported for overall cases. They haven't taken out cardiogenic shock or salvage out of your grading, the rating. So there are some programs that I know that have gone to complete BAV because of that. Yeah. But I think we are in the same strategy overall that BAV and TAVR have the same risk. So if somebody has a longer survival, do it. But I think we tackle these cases once a month now. And if you have 2 mortalities in 2 months of these, you do something and the patient dies, then suddenly the 3rd month you're like, should we still do this? What do we do?
But you are treating with a balloon valvuloplasty. You are putting an Impella, and you are letting them recover. Because even with a TAVR, you still have to give contrast, and although you have slick ways of getting your TAVR done, we all can come up with slick ways. It's just nice to do it in a little bit more of a controlled setting. The only time my program does an emergency TAVR is for aortic insufficiency valve and valve, because there is no treatment for that. There's no hemodynamic support for that. This one I would have done BAV. But let me ask you this really quickly, Paul. Which one would you have done? Balloon self-expanding or intraannular, superannular? What kind of valve would you have used emergently?
I mean, so if there were an opportunity to get even a non-con CT to look in my... Yeah, okay. So, I would look at the LVAT.
That was the fortunate part because he came to clinic on
That's
Friday.
nice. So, if there's no LVAT calcification or anything that's hazardous, it's dealer's choice. It's whatever you want to do. But if you had no opportunity to get a CT, I would do self-expanding because I just wouldn't know what the annulus was and such, and I would size it by echo.
Okay, I think in the interest of time, we'll proceed. So what we did, we actually just left the Impella in and stabilized the patient. Actually, a nipride was added. He was still not intubated. And by Monday, actually, he was feeling a lot better. And then again, it was still a decision making of where do we go from here, and we decided to proceed with balloon expandable valve on Monday afternoon. And what we did was actually, obviously did our root shot, took the impella out in the case, deployed the valve, and left the balloon in, and then actually I was able to just push the impella back in because we did not think the patient would not do well or would do well without any support. So I left the balloon in to kind of just pin the leaflets open, and then just was able to push the impella back in from the left side.
So, Kashish, what about the pacing? Like, can you just kind of take us through like your mind?
Yeah, so that's a good point. So what I do for, I've done a lot of these now for low EF patients. So as you see, we have pacing. We still pace at 180 and not like normally, but I will give them epi with anesthesia before deployment, and I'll give them, we have 10 mics per ml baby epi stick on every patient with low EF. And as soon as the valve is deployed, I give 20 mics in the pigtail directly. And I don't know how many patients we have been able to resuscitate quickly because of that. Basically, you just it goes directly into the aorta. There is no need for anything else. Anesthesia, the venous line takes about 2 minutes, and then you never know by that time the patient is gone. So in these patients, that's what I do. And then again, we had the impella back in as well. So
What was the dose again?
So there is one is the code dose epi, that is they have, this baby epi stick is 100 mics per 10 ml.
Okay.
And we break it, and we have 10 cc's on the table. And I give 20 mics per ml. And I always say hypertension is tolerable. In 2 minutes, the pressure will come down once the epi veins off. But then early on, if you can resuscitate the patient, that's what's really needed.
Yeah, I think that IV dose, I think I've seen people make the mistake of giving that full dose.
Yeah, the baby epi dose. Again, we just did a recent case with right heart failure, and basically all the drugs were in the right side. On the right side, we had to do CPR to get the drugs to the left side to resuscitate the patient, but the patient still came back. So overall, the impella was then, we weaned off the impella about 3 days later. Patient was discharged 7 days later. Discharge EF had improved, but this was the most satisfying part. At 1 year, his EF was normal. So overall, I think learnings for us is that early TAVR and obstructive shock may be better than delaying treatment overall. And we actually just published, cardiogenic shock in TAVR, the mortality is about 70%. Survival is about 70% at 1 year. So in general, I think our philosophy is if the patient is an anatomic suitable candidate and we can absorb some mortality, I think TAVR is the best pathway to go. And TAVR can be performed with an in situ impella. We've done this a couple of times now. Obviously, if you have tandem heart, that's possible too. Thank you.
Grace?
Mark, what would you have done? This exact thing?
No, I wouldn't. I would have done a BAV. And I might have done a BAV before the impella, rechecked the hemos. I don't know how sick this guy was. He was obviously sick, but how acutely ill he was. Syncope is syncope. I would have done a BAV, would have done some good hemos, plus minus an impella, and then I would have sent him home if I could. And I'd have to fight with the heart failure doctors every 2 hours. But if they felt comfortable sending the person home, I would probably send him home.
And I would do the same because he trained me.
Yeah, and all of our patients.
What
don't do
happens
well.
in New York, Bruce? Bruce, what would you do?
I would say similar to Mark's approach. I mean, I don't think it's a one-size-fits-all. It's a case-by-case in terms of, I kind of lean towards your feeling, Paul, though. If we're doing a valvuloplasty, we should just put the valve in at that time, unless we think there's some absolutely prohibitive reason not to. And we don't get too caught up in the whole mortality and recording and yes, we just
I would just say that the outcomes that Kashish just presented with regards to shock and TAVR, I would not call them great outcomes. So I think that there's probably room to develop that pathway. So the staging approach and the prehab that you kind of deem to be appropriate for a lot of patients is probably even more essential in the sickest patients.
Yeah, I think for us, we have done 2 valvuloplasties in the last 6 years. We have not, and I think Colin, my partner, is also basically on the same page. And we basically said that if you look at all the valvuloplasty data, even TVT, or not TVT, like NIS and others, there is 3% to 5% mortality with BAV. So it's similar to TAVR actually, mortality-wise. The more issue comes in because we are judged on TAVR mortality and people are doing that way.
Yeah,
So
but think about who's getting TAVR'd versus who's getting BAV'd, right? Like this isn't like RCT propensity match
That's
data.
the
You know, there's a lot of selection bias thrown in there.
And it's so nice to have a little bit of time on your side by having just that bridge to recovery, bridge to TAVR. Well, these patients are so complicated. The next thing you know it, they have a UTI, they have a stroke, they have something. There's just so many competing risks with these patients that are coming in with cardiogenic shock. It's rare to see isolated cardiogenic shock. They also have some relative contraindication, like an infection. It's just that time, I think, is really nice. It's a nice stress test to let them recover.
And I also think that, to me anyway, the most important slide you showed was the calcium on the valve. So now this is true, real aortic stenosis. And I think so many times, especially with aggressive heart failure docs, they're like, well, this has to be the valve, even though the area is 1.2. It has to be the valve. And I think if it's true AS, patients otherwise very viable, was just seen in clinic the day before, you're probably going to win on this one. You're probably not going to take a mortality hit. But it's just it's tough. But the BAV does buy a little bit of time.
All right, fantastic. Great start. Hemal, you're up with the mitral case.
Good morning, everyone, and thanks, Paul, and everyone at CVI for inviting me to this really great conference. So I'm going to do a mitral case. It is mitral repair, but it is not TEER. So an 84-year-old female, past medical history shown here. Of interest, she had a mitral valve repair with a 28-millimeter Edwards Classic CE ring, which is rigid and complete. That's a 347 millimeter squared on the bench area. So some of the sizing considerations, we can kind of talk about that and what you would do for a variety of different rings. We could stick at the Edwards family and talk about CE, Physio 1, Physio 2, and how you manage those as far as sizing is concerned. I'd really be interested to learn from the panel with regards to that. Adriel Flutter had an AV NRT ablation in 2016, presented with NYHA Class 3 heart failure symptoms. So this is a complex patient. She also had severe tricuspid regurgitation, and we deemed her to have low flow, low gradient mitral stenosis in the setting of severe TR. Obviously, all of the orifice measurements that we did were kind of consistent with severe mitral pathology, and honestly, we wanted to get her TR treated through a clinical trial pathway. We had no commercial devices available to us at the time. And so really, we sized her for an Intrepid, a 48 millimeter Intrepid TTVR, and we were going to put her in the Intrepid TTVR trial. So this is like kind of a complex decision making. Like, okay, we think the mitral valve is enough of a problem to exclude her from that study, and we do think that the mitral valve is adding to her NYHA Class 3 pathology. So that was our indication to treat. This kind of stuff gets sloppy because it's not set in stone, and this isn't someone that's like kind of screaming with all metrics like, okay, yeah, replace the mitral valve and you're gonna make her better. So we're just kind of like trying to facilitate an overall treatment strategy for the patient, which was obviously like frustrating. And so she was deemed prohibitive surgical risk. We had that discussion. We thought that getting her a comprehensive surgical fix, if it was offered, would be her best solution, but the surgeons were not having that. And so we decided to proceed with a valve and ring TMVR with future reevaluation of tricuspid regurgitation for possible transcatheter therapies. And obviously, in the back of my mind, I'm going, well, TR is not going to get significantly better. We're going to end up treating that anyway. So we ended up doing tip-to-base lampoon. I mean, I think that my mindset on this has kind of converted more over to Batman Cleave for these redundant anterior mitral valve leaflets. But tip-to-base lampoon is just so easy to do. There's going to be some element of overhang when you put a sapien into these pathologies, no matter what you do. And given how easy and straightforward this is just kind of a default strategy for us with all of our valve and rings. So again, fodder for thought. You want to make any comments about that?
Well, it's a great question. Batman versus tip-to-base lampoon. I'm looking at that anterior leaflet. It looks like something you'd be nice to pass a sapien. And Kashish, what do you think? Would you rather do Batman or lampoon here?
I think since attending CVI last year, I've only done Batman or unicorns. I've not done Basilica or Lampoon since then. I think last year, like every case was a Cleve or a Batman. And I'm like, this seems so much easier. And, I had my first was a unicorn. And we obviously, give time for those cases. And we're like, oh, we're done. It's so easy. So I think if it's doable, obviously now we have switched.
Yeah, I mean, this is obviously pretty easy as well. So, yeah, what about efficacy? Like, I mean, any concerns about one versus the other with regards to that?
I think what you said, Hemal, yesterday as we were discussing, if your fulcrum is not in the center, like you can see sometimes as you're pulling back the tip to base, it just comes medial and you're tearing it from the side. Then you have to redo it.
So I've totally noticed that. And honestly, it's dependent, yes, on the anterior mitral leaflet, but it's also dependent on the angulation and the relationship between the aortic valve and the mitral valve. The more of a 90-degree angle that you have, the more central to that second scallop of the anterior leaflet you'll be, and the more successful your tip to base will be. When that angle starts getting lesser, then obviously you're not going to have that level of success. Your catheter is then more primed to find, or your flying V is more primed to find some sort of cleft, some sort of like area in between scallops, and you're not necessarily going to get that slice that you want on that anterior mitral leaflet.
Hemal, can you give us a little bit of data on the neo-LVOT you're dealing with, as well as the leaflet length of the anterior leaflet?
Yeah, so I mean, like all these repairs, the anterior leaflet length is long. It's over like 2 centimeters. So that was our predominant concern. Neo-LVOT was not going to be an issue.
Okay.
Not going to be an issue. Okay. But yeah, this is something that we just systematically started doing because there's this area of overhang. I believe that will affect hemodynamics to a certain degree. If you have a really healthy LV, you're going to generate flow after this procedure. You may have physiologic LVOT obstruction to some degree.
So there's no neo-LVOT concern, but you're still doing all of this in every TMVR. I know it's easy to do, but it's not without risk.
True.
And
True.
I guess you're putting cerebral embolic protection in all these.
No. And so, like, I mean, if we're talking about like a non-calcified anterior mitral leaflet in a ring, no, we're not doing cerebral embolic protection on those. So yeah, I mean, I agree, it's not without risk, but I've seen now a good number of patients come back where the neo-LVOT was fine, but their velocities across the LVOT are quite high. Greater than 2 meters per second.
We had, during the mitral session this week, we had a lot of discussion about the neo-LVOT and how unimportant it is when the anterior leaflet is really long.
Exactly.
So Mark, Richard, do you want to comment on it?
In the original teachings, when valve and ring
Yeah.
first getting popular, this was just one of the things we looked at.
Yep.
But the AML length,
Yes.
aortomicro angle you mentioned has to be paid attention to, and so I think neo-LVOT is not enough. So many things.
Yeah.
Never just one thing. So I think doing this is fine. I think I agree with the fact that a lot of the electrocautery advocates like the precision of it, but I think in reality, depending on where your fossa is, where you stuck, your angle, I hadn't thought of that. Great thought.
Yeah.
You may slide off to the side and not get.
So what stroke risk would you quote this patient to Mark Gajjar's question?
I don't think I would quote one. I don't know of a stroke risk
Yeah.
that's associated with this.
Yeah.
So
no
why not
stroke.
use cerebral embolic protection?
Because cerebral embolic protection, what, Sentinel? Sentinel?
Yeah.
Give me some data that supports Sentinel use.
No.
We
we
do
do
tend
Sentinel
to put
because it
Sentinel.
feels good, and so in our practice, if we think there's going to be a chance of multiple burns or a calcified leaflet, we'll consider a bilateral Sentinel. But it's we've done that in some of our cases. This one I could see why you might not, especially if you're doing a flying V and it's just a single cut.
Yeah.
But I guess another question is: the field moving towards empiric leaflet modification for all TMVR? Is that where we're headed here?
I think if the anterior leaflet is really long,
I think for
or the
rings,
neo-LVOT,
I don't see a reason why not.
Yeah, and the neo-LVOT or the neo-LVOT is borderline, or if it's a ring that, that's the number one failure of valve and ring. It's the LVOT. So
And we
It's
had
this toilet seat anatomy, right?
Yep.
There's
Yeah.
no PML.
Yep.
It's meant to be all
Yeah.
AML to cover that annuloplasty. So I do think for most rings.
I had
Yeah.
a patient with very large LVOT where I didn't do it, and actually we had valve dysfunction as well because the anterior leaflet was just hanging on.
Yeah.
and was stenosis actually. So we had to go and do reverse lampoon
Yeah,
in
overhang,
follow-up,
yeah.
which
Yeah,
is
yeah.
painful.
That's painful.
Okay.
All right, yeah, so that was a fun discussion. So anyway, we're going to go ahead and deploy our 26 millimeter Sapien 3. So again, 347 millimeter squared area on the bench for this CE ring, but this thing deforms. And again, kind of like you're subject to your own history. I've had this same case and I put it in 23, and then I post-dilate a couple of times, and then maybe plug one of those cases, and so now I just go in with 26. Like, I mean, if I need at least 20 to 30% oversizing on these cases, because you have no idea what that ring's going to do when you deploy the Sapien. Now, a couple of pearls here. So we couldn't get the Safari wire to sit quite where we wanted to. I would really like to have preferred more of a true apical lie here, and there are a couple of reasons for that. You could see the trajectory that we're coming in, and honestly, we planned the transeptal not as low as we used to go. We used to go like 1.5 to 2 centimeters above the valve plane in an inferior posterior kind of stick, and now we're kind of cheating up a little higher, not towards the aortic valve per se, but maybe making it more mid-posterior to get a little bit more height to guide that trajectory. The other thing that we've been doing is now we take all of the flex off the delivery catheter once we're through the valve apparatus. And what that allows us to do is actually push the delivery catheter forward to get a lateral to medial deployment of the valve. That is not what's being done here. And so the Safari position, the fact that we still have flexion on the Sapien delivery catheter creates this canted deployment, which in a lot of anatomies you can actually avoid doing. I find it to be even more critical in valve and MAC cases, where you really want to get that trajectory down, taking all of the flexion off and basically pushing on the wire while simultaneously pushing on the system to guide that lateral to medial deployment, I think is just so important in those cases. And so we end up with this PVL, and looking at where the PVL is, you're like, okay, did we miss something? Did we miss somewhere? And that was my initial thought, because if you just look at where the valve is deployed here, you're like, oh crap, on that anterior medial aspect, we have PVL, but the TE is not showing that.
Was this an S3 or Resilia?
No, this is S3,
S3. Yeah. So this could be it looks like a skirt PVL
right?
on the lateral side. It's what it looks like.
Yeah.
Or is it a rigid ring trigone leak because the ring did not circularize?
So, yeah, we do the 3D imaging, and you're both wrong. So,
I love it. I love being wrong.
3D imaging that the PVL revealed the PVL was actually due to annular tissue dehiscence outside the rigid annuloplasty
Oh,
ring.
Well, then you just plug it.
Yes, exactly.
Wait, new or old?
What's that?
New or old?
New. This was new.
Unrecognized.
Unrecognized, right?
Oh, did
Okay.
you? Did it
made it
happen
worse.
from your? did
We made it
happen-
worse. I would agree
Yeah.
with you. I think that we probably
exposed
saw it as really small. We didn't value it or whatever. We made it worse, right? You stretch out the anatomy, you make it worse. And now, yes, you plug it, right? The point is that you can't assume things that, okay, well, I just missed, and now I'm going to put in another Sapien to fix the problem. Take the breath, take the step back, do this, and you get a surgeon's view 3D. You can actually diagnose exactly what's going on.
Just Hemal, to that
Didn't
point.
show us all the images.
What?
Yeah.
Just stop.
I was just saying,
right.
we did one case in an acute ring once because the surgeon tried to put neocords and the ring failed literally 4th day, and it was worse than this. And then since then I've said we're never going to do a valve and ring in an acute ring case, just go to surgery again. Basically, as soon as we deployed, next day the patient had severe hemolysis, and we realized the whole annulus had come off.
Yeah.
So I think since then I said we're not going to ever do a acute
Yeah, it makes
ring
total
again.
sense. Yeah, no, you need some fibrotic tissue to build. So then we use the steerable sheath. We plug this thing, right? So we measured it as a 10 millimeter AVP2 that we went in, used the mother-daughter telescoping technique, and just plugged it. And I agree. I mean, the resolution is easy. The diagnosis just requires that additional step. So that's it. So she got the stable S3. Everything looked great. And then we eventually treated her in the Intrepid TTVR study. Thanks.
Fantastic.
Oh, special thank you to my fellow over here, Ahmed Ghanim. He put together this. He actually had presented it previously. He is a third-year general cardiology fellow. He knows a ton of structural. He's very interested in interventional and structural. He is open for recruiting. So thank you.
Yeah, we actually need a job board.
Not a bad idea.
All right. Great idea. So I'm a last minute fill in for a couple cancellations, so I can't remember what I'm presenting, but we'll go through it. So, oh yes, okay. All right, so this is an 80-year-old man, and he's here for, we think, an ASD. So his history is that he was really complicated. He was in our hospital for several months because he had his mitral done. He had a 29 epic. He had everything. He had cardiogenic shock. He had dialysis. He had a stroke, and he actually came to us because he had evidence of TR and follow-up that was not evident at the time of surgery. And the question is what the cause of this was, and it was found to be some funny ASD. So if any of you can quickly make sense of this, you're better at imaging than me, but it took me a little while to sort this out. But obviously it's a TE, and you can see that there's this pretty significant communication that goes around his mitral valve prosthesis, and it goes into his right atrium, right above his tricuspid valve. So it's almost like a gerbode, but not a gerbode, because it doesn't go into the RV. I'm not sure that last one. There you go. All right, so I think, okay, ASD.
Are those short axes? I'm sorry, was it or that?
So that's what's funny, Mark, is that these are not conventional views, and because these are the only views that would show it. There's a short axis in the left, just to show you that there's a mitral valve there, okay? But if you look in the middle, that's where the defect is, and that's going around the ring. And you can also see looks like a defibrillator or a pacemaker lead that's going across the valve. And then I'm sorry if the right hand side won't play very well.
It's already unsettling, this case, when you have to go off axis to find.
Yeah, exactly. You can see the leaflets there. So it's a pretty significant, it's a paramitral ASD. So we think, okay, well, ASDs, these are easy, right? We close these ASDs all the time. Not a big deal. So we go in and we try to close this, and I can't find it. Okay, but yeah. So
You guys have pretty good imaging at your place?
yeah.
Did you think of other types of imaging before you went in?
So we did, but okay. Let me just finish this slide here. So we weren't going back to surgery. His first surgery was so complicated, and we were going to try to close it. There was some concern about how to closing it, and also worsening his TR. And this is what we try to do initially. Okay. Before we get to your question, Mark. So we came up from the groin, had a Destino, and we were steering towards the defect. And, we thought ASD again. Should be pretty easy, right? And all I could find was the coronary sinus. See my wires in there. I have a JR, I have a glide wire. I try different coronary wires. I try different combinations, all the different MP telescoping catheters. And despite these beautiful images by our expert imager, we could never find this defect.
Do you think about using ice?
We tried ice, yep, and couldn't see it any better. And so then I began to wonder, where is this defect? Where is the origin of it? So what would you guys do at this point? Any thoughts?
What Mark said, stop and get a CT, 4D CT, figure
Yes.
out.
So we did. So we went and got a CT. I can't remember if I have it in here or not.
Since you're invasive right now, I
Yeah.
guess, could you do anything more to learn? I mean, you got all your catheters in the right place. What about
Yeah.
an angiogram, a
We
bubble
did an
study?
angiogram. Yep. We did an angiogram and couldn't find essentially we're looking for this hole. And it's a good sized hole, don't you think? We should be able to
Definitely
find
have
it.
Communication into LA.
So
when
it's we thought about actually transeptal LA and coming back through it to go through into the RA, but I wasn't confident we'd be able to make the turn. Okay, so couldn't wire it, so frustrating. So we actually took them off the table, and we thought, well, there's got to be some other way. So then, basically, I became convinced that the mouth of this defect was pointed towards the RV, and that's why I couldn't find it. And so you know, if you can't align things in one direction, it's because the opening to it is facing another direction. And so we spent a lot of time trying to find it from the femoral vein. So obviously that the mouth is not directed that way. So then I thought, well, it's got to be facing the RV. So how can I take one curve out of the way? Well, coming from the neck, I thought we could just hook it, kind of like a fish hook. And so there's a dry seal in the IJ. There's a Destino going through the dry seal, and then you can see an MP catheter. And guess what? I keep finding that corny sinus again, and it was getting a little bit frustrating. You can see here. Then what happened was I took a JR, and this is the hook. And if you watch the left-hand image, there it goes. Isn't that neat? So it's one of those things that it's kind of like, wow, this is so big. How could I have not found it with a wire? But honestly, all it was is just an angulation issue.
You are a patient man.
Wait, did you put your ice catheter in the RV and explore it that way too?
We did. But basically what we concluded was on the echo, the opening was facing the RV, and the opening was also dynamic. So it was opening and shutting. And so it was two things. So, and then eventually this catheter was strong enough to overcome that flap that was opening and closing, and we just shoved it across.
That's great that you found it, but how are you going to determine if you have adequate rim tissue, sizing?
Yeah, so we told the patient there are a lot of things we don't know about this case, and I also warned him that whatever occluder we place is going to be right on top of his tricuspid valve, and he had come to see us because of his TR, and that actually if I close this, I don't know if it can make the ASD better and also make the TR worse, or not be successful in closing the ASD and affecting the TR as well. So honestly, Mark, the imaging was so poor that I just told him this is really unpredictable. So this is a true Hail Mary. So we're just trying it just to see. So we put the JR into the LA, you can see on the right-hand image. And at this point, the imager Nadira finds me on the echo and said, yep, you're finally across something. So we do that. So, and then over the JR, it's amazing. Look at the Destino now. This Destino over the Safari, over the JR, follows it into the LA. And then we pull the JR out, and you're left with just the Destino. And then if you look on the right-hand, I'm sorry. If you look in the middle, I put a safety wire, and it's a little bit hard to see, but in the middle of the picture in the middle, there's actually a 16 millimeter occluder, and that occluder is brought back, and I have a safety wire out. It's probably in the appendage, but I didn't really care. So I needed something to stay across in case I lost this. And then in the middle is the final, the far right hand is the final deployment. And what was beautiful is that this is the final picture, so you can see. It's not a great result, but the most important thing is the defect was closed, and on the right-hand side, all of his tricuspid valve leaflets are still moving.
I'm struggling to actually figure out where exactly is defect, and yeah, you've been talking about that, but where this is, because I mean, the tricuspid valve is not near where your occluder ends up.
It was right underneath it.
It's right. Okay, right
Yeah.
underneath
So
it.
so if you look, let's see here. Probably the top image. There's a short axis.
Yeah.
And then the orthogonal view on the right hand side. You can see the tricuspid valve is right underneath. And actually, if you follow the pacemaker lead, that tells you where the tricuspid
You got
valve
a
is.
blown out annulus, so that actually worked in your favor there.
Yeah.
How
So
did you
anyway,
size the device?
we guessed.
What?
Yeah.
What about balloon sizing?
I didn't want to balloon this. It's a good question.
Yeah.
How did you
but-
pick 16? They come in. There's so many sizes.
Yeah.
It's his favorite
guessed.
number.
Did you pick?
Yeah.
Did you measure?
Basically,
So you had a good view.
We
You
had color, and I almost always take 1.5 or twice whatever the color says, and that's what we did. Yeah, and then because I didn't want, because this defect was probably friable, I didn't want to make it worse, and honestly didn't know where we were. I was afraid of ballooning things that we just didn't understand. So we did great. So it was a nice case.
What was your push pull, or did you do a push pull?
Oh, I did. Yeah, I
And how did
pushed
it
full.
feel?
Well, it's funny because it's from
At
the
that
IJ,
point-
it's
yeah,
180, so everything's gonna feel okay. So
Yeah, I was gonna say. Well, at that point, I mean, at least one curve is gone because now
Yes.
you're up against the defect, and so you probably had like pretty good translation of motion there.
yeah. So anyway, so the key learnings are, if you've got a dynamic opening facing the wrong direction, try to get or try to pick an approach that comes to that opening as much as possible. We used a right IJ to take away one curve. We have had cases where we've had to take a Destino and take a JR and take something stiff and go in opposite directions, but it can be really hard. This defect was next to the tricuspid valve, so the most sensitive thing in him is his tricuspid valve, but we managed to avoid it, so it was okay. All right, who's next? Any questions about that? Bruce, you're next.
Hey, thanks so much for having me. Great couple. This is a tricuspid. Okay, so this is an 85-year-old our valve clinic, fatigue, short of breath, NYHA3. Was found to have massive secondary tricuspid regurgitation. Patient had an extensive past cardiac history. In the interest of time, I didn't put in all of the imaging, but suffice it to say, coronary disease, multivessel PCI, it was remote. Atrial fibrillation, had GI bleed with an appendage occlusion, sinus node dysfunction, tachybrady, and had a pacemaker, which was mostly RV paced. HFpEF with a cardiomems, now presenting with a component of right heart failure. And our team had done, I did a previous MTR with a Pascal about a year and a half prior to this presentation, residual 1 to 2 plus mitral regurgitation. It was complex anatomy. He wasn't deemed a surgical candidate at that time, and we knew he had some TR at that time with plans for potential future intervention. So for us, clinical challenges, what is the best approach to manage a patient with severe TR? He had a pacing lead, of course, and right-sided heart failure. So typically we have all these patients seen by our EP colleagues. As I'm sure all of you have met, we work with a very passionate, enthusiastic, and high-volume lead extractor, Larry Epstein. He's been a really critically important partner for us in our tricuspid program. Our heart failure docs have also been very helpful in managing these patients and getting them as optimized as we can on GDMT. Of course, the questions are, should the lead be extracted prior to consideration for TR intervention? It's quite controversial. We've been talking about it a lot lately at the recent meetings. And of course, it always comes down to the same discussion. What's the risk of lead extraction? Do you have someone in your center who can do lead extraction, who's comfortable with it?
But Bruce, you have Larry Epstein.
Right.
So question number 2 is always yes, right?
It's
How do you manage that?
It's You're saying you're saying what's the risk? Or
No,
should
how do
we
you tell
extract?
Larry? How do you talk to Larry about risk?
Yeah, I mean, it's really we send him the patient and let him sort out the risk. And in his opinion, most of the leads get extracted.
Yeah.
We're just putting together our paper. We're up to about 30 extracted patients that we've gone on to. We're going to discuss the results of either not needing any intervention or going on to have intervention and what we did and what we found.
This is fabulous. I mean, when you get that paper, please forward it to me, like even before it's published, because my electrophysiologists need the education. They won't extract. I mean, they'll extract ICD leads for obvious reasons. You fracture that, you have problems.
Yeah.
But they just won't
You know,
extract pacemaker leads.
He's really opened my eyes to a lot about lead extraction. There's clearly a perception, I think, that's probably not realistic or justified, that the risk of lead extraction is excessive. People are saying, what's considered a high-risk lead extraction? A lead over a year old, and he's like, up to like 10 years, he's like the lead. He's like 3 years the lead comes out. He does it in the cath lab with no surgical backup. 5 to 10 years, he'll do them on the hybrid OR with surgical backup, but they come out easily. And he's taken out leads, honestly, that are like 20 and 25 years
That's
old.
awesome. And I mean, so they'll do it, but they won't do it for this particular scenario, which irritates me.
So it's been, for us, like I said, it's been a huge help for our program. And, and he'll show you the slides. The risks of lead extraction are not excessive. And he'll say it's less than the risk of a TAVI. He'll say the risk of mortality from a TAVI at 30 days is what? 1.8, 1.5, 2%.
In his data, he quotes
lead extraction, it's
0.6%.
It's less than what he says.
Yeah,
It's less
which
than
is,
what he
which
says.
is extraordinary.
Larry came to me after my New York Valve presentation. He's like, why didn't you take this lead out? He's like, I'm going to call George Crossley tonight.
Yes.
Our problem is EP consult takes 2 to 3 months, and lead extraction will be 2 to 3 months after. So I've told the EP guys, like, if this is going to take 5 months to get the lead extracted, patient is not going to wait.
So Larry and I, our offices, are literally down the hall. He's down in cardiology. I'm in cardiac surgery. And we frequently, when he has his clinic, he will walk a patient down the hall and say, I just saw this patient with severe TR and a lead. Can you see them today? If I'm not in the OR in between cases, I'll see them the same day, and vice versa. Some days we'll trade patients both directions, same day visit. He gets a lot of patients who come from pretty far out for the leads also. And I'll see a patient in clinic with TR and a lead, and I'll call him up. You free? Yep. Add him on. Bring him down the hallway, and the lead's gone 2 weeks later.
Yeah, I'm saying, we've ours is also a big extraction program. Sometimes the EP guy will come and stand outside the evoke case. He's like, why is this lead not, I was like, we called you. You didn't, take care of this. So we have a patient in the hospital right now. We'll just take the lead out right now. So then we can do a TTVR in a month or so. But that's, I think, our, we have talked to them. Maybe Larry needs to call.
Yeah, I think this movement is growing. I think that we're going to probably start also to see the sequelae or the effects of trapping some of these leads, and I think it's probably not going to look pretty. I have a feeling it's not going to be too. It's going to become. I mean, according to Larry, he feels that consideration for lead extraction should be like a class 1 indication in someone who you're considering for TR intervention, and we may see some changes coming up in the EP guidelines that suggest. That at least all of these patients should be seen by an electrophysiologist.
And then does he just do 100% micro after that, or was he doing?
Interesting. So not 100%. So we'll talk about what procedure we think we're going to do. The one thing he's done with the micros, and I remember, Paul, at this meeting, I think it was a couple of years ago, you had expressed some concerns about micra causing trouble for future interventions, but they've been implanting them so high up on the septum that they're out of the way. So these micros are not going into the RV apex. When we go on and do replacement or even edge to edge, they're nowhere near where we're working.
But that's a catch-22, right? I mean, like, you get an effective result with a replacement, then you get the remodeling over time. You've got that micro already shoved up fairly high. I mean, what's preventing it from messing with the valve function over time?
We haven't seen that, but obviously, I guess time will tell.
We haven't seen any micro issues. My issue is in the trial, we did a couple of, post-evoke micras, was the RV pacing that I think the patient's in. Like the TR is gone now, but the patient doesn't feel well because they don't have any synchrony and they're feeling bad.
Yeah, it makes sense.
So, and again, there's a lot of options. He's putting in CS leads. He's done some combination approaches where he's put in a pacer with a right atrial lead and a micra, to preserve.
Heck, man, I mean, this guy could just snare and take out the micro then and just throw in whatever afterwards, right?
So, and the reality isn't, I didn't expect to spend so much time on this one point, but in reality is that sometimes it fixes the TR and they don't need any intervention at all. Clearly, we knew in this case that was not going to be the case. But I would say at least probably approaching 20% of patients, the leads come out and the TR has gotten better and the patients didn't need anything further done.
That's almost exactly our data. So
yeah.
we published a series of 33, and 1/3 of the time the TR got better, and those patients didn't need treatment. So
Which is, of course, for the patient, the best. And it could be another hour-long conversation of how we decide on edge-to-edge versus TTVR. But in this case, we already knew that this patient was going to be more of a replacement just based on the extent of the jet, which we'll see in a moment. Again, in the interest of time, just the pertinence, patent stents, moderate pulmonary hypertension, which was corroborated by echo, normal left ventricular function. RV was enlarged, but function looked good. Biatrial enlargement, and you can see the rest of the numbers there. And massive secondary TR was atrial ventricular secondary with the lead. We did a CT on this patient, so here's another point of discussion. Who are you CTing, who are you not? Our approach, especially in patients with leads, in this case, I think shows why it's a good thing. If they're renally competent, we get a CT and a T on all of our patients that come through our TR clinic, and that way we can assess all of their options going forward. So we already had a CAT scan on this patient. Granted, you can say if you take out the lead, is it going to lead to remodeling? Are things going to change sizing? But we resize all of our tricuspids in the room anyway when we do the valve, right? And there have been some cases where we've sized up and sized down, in the room after other interventions. Here's our screening transthoracic. Obviously, you can see the TR. I'm sure Paul would say this would be okay for edge to edge in his hands. But for us, we're kind of always trying to find the line between edge to edge and replacement. But I think for some of the kind of yellows and greater with really huge jets that are across the entire valve, we're just no longer happy coming out with, even though the patients do feel better, we feel that if we can get some, unless we can really think we can get them to mild or less tricuspid with an edge to edge, I would say we're leaning towards replacement. Not getting into this, I'm just showcasing an algorithm that our team put forth in NeuroPace, just looking at our algorithm, how we approach patients with leads. And in this case, ultimately our decision was to extract. So here's our intraoperative TE after the lead extraction. And while we all say how safe it is, or why Larry will tell you how safe it is, you can actually see that actually it made the TR worse. And you can see that the leaflet was flailed. You can see that in the right side.
This is why we always have a backup strategy of replacement. Because, even if we're doing these to help facilitate possible repair, I think you do have to have a CT scan and have a replacement strategy ready to go. It's even in the best. Larry is one of the best in the world, and it happens.
And it happens. And we knew it right away. And what's interesting is and this kind of shows this, how you can get kind of fooled. You say, oh, they already have massive TR. You can't really make them much worse, but you actually can make them worse. And just that little bit of a flail, and it wound up being a little bit of a red herring. So that night, this patient actually went to CCU. So I wasn't quite involved. I knew of the patient, but the extraction I knew. And that night they went to CCU, and they got a call, and the fellow got a call that the patient was hypotensive and had an effusion. So the effusion was drained that night. Actually, Larry came in and drained the effusion. Pericardiocentesis, and everything we thought was looking better, or they thought was looking better, but they really kind of mismanaged the patient. It was an overnight fellow in CCU. They weren't even thinking about the TR. They were just so focused on effusion, and they just loaded the patient with fluids. So you can see here on the right, that was a transthoracic the following morning. The effusion was gone, but now the RV wasn't looking too happy. And basically that day we convened an urgent heart team meeting. And actually, I have to say, it was our heart failure colleagues who basically said, this guy's in big trouble. This was the day after the extraction. He was going into worsening shock with multi-system organ dysfunction. And they called us and said, is there something that we can do for this guy more acutely? We knew, based on the CT, as I mentioned, that the patient was a candidate for a 56 evoke. Here's some of the details of that. Anatomy looks pretty reasonable. We've got good heights, good sizing. Not too, the offset was manageable, as you can see there in the middle picture. All of our heights were good. We had generous sizing, and really at this point, the only acute watch out was the fact that the patient now had a flail. But I won't get into the details, but if you have a flail in the tricuspid and you're considering a replacement, The flail, I think the criteria is it can't be more than 50% of the leaflet, otherwise you're not going to be able to latch on, and that would be the concern. But in this case, it was a partial flail, less than 50% of the extent of the leaflet, and the team from Edwards felt that the case was doable. We actually contacted them that day and said we had a patient who needed to be treated urgently, and I will say, to their credit, we had a team that was in place and was going to be able to come basically about 48 hours later. I think this was a Wednesday, and we booked the case for a Friday. So resolution of the challenge, given the evidence of acute on chronic RV failure with shock in this patient, we made the decision at that point that they weren't going to make it 48 hours based on how things were going. 85-year-old, we got our MCS team involved, and I went with one of our cardiac surgeons, and we put the patient on VA ECMO as a bridge to intervention. So there was a lot of eye rolling, of course, from members of the team. We're putting an 85-year-old on ECMO. What are we doing? You know, we shouldn't be doing this type of stuff. But we felt that we had a therapy that we can offer the patient. We just needed to buy him some time. There was no way he was going to survive 48 hours in the current situation without some form of support. Edwards, as I said, put the team in place, and we had the case scheduled. This was on a Wednesday into a Thursday, and now we were scheduled for Friday. And ultimately, you'll see the results. We did
So Bruce, just super quick, it's a great case. The mechanism, it seems pretty obvious to the effusion.
Effusion actually was from, you know what the effusion was from, which I didn't get into the details. He struggled for a while trying to place a right atrial lead. And actually the patient, in reality, was probably more of a chronic fibrillator than anything else. And he said in the end, he regretted doing that. He was trying to put in a micra and an RA lead for the patient should he need some degree of dual chamber pacing, and it was from the RA lead that he got into trouble.
So the other mechanisms that everybody's thinking about may make it tough to fully anticoagulate somebody just a day or two after.
Yeah,
you know.
He thought it was kind of like more of like a micro perf from the RA, and actually I didn't even include it in the presentation. But when we went into some imaging the next day and he got a chest X-ray. He struggled with the RA lead, perfed, caused the effusion, and then the next day the RA lead was basically swinging in the breeze and had dropped off. So actually, when we did the evoke, Larry came in and he pulled out the RA lead at the beginning of the case. So we did that at the same time. Here's your result.
You didn't want to leave any evidence behind.
So what's that?
You didn't want to leave any evidence behind.
Exactly. Here's our final result, and just you can see the extent of the hardware. And we've seen, I feel like, tons of images in the last couple of days. So you can see, if you look closely, right, you can see a bunch of coronary stents, a cardio MEMS, a Watchman, the Micra. You can see a CS lead, a Pascal, which we put in 18 months prior. You can see your venous ECMO cannula there, and there's your tricuspid valve. So some key learnings for our team, patients, of course, and I threw this in general, patients with TR are complicated, often very sick, and they need to be treated earlier in their disease course. So one of the things we've gone out with all of our referrings is really ask people to send us these patients sooner, because I think the sooner they come in, less enlargement and less sequelae of their TR, often I think the outcomes will continue to improve. About a third of the patients have leads, and about a third of the patients with lead extraction can actually improve. Leads obviously can make our procedures more complicated, getting in the way, imaging issues, et cetera. While lead extraction is safe in experienced hands at a high-volume center, it is, of course, still invasive and has potential for risk. As I mentioned, we routinely get a CAT scan and a CT on all of our patients, so we know what our options are going into any intervention. And that even goes, if it's someone who we're planning on an edge-to-edge, we'll still do a CT if we think it's a good edge-to-edge case, because you never know until you're in there how it's going to go. And if we're in there with an edge-to-edge and we're struggling, and we only happened to us in one patient where we really had a tough time and we just weren't happy with what we were going to be able to achieve, you have the option of potentially aborting if you know that the patient is a replacement candidate, and say, you know what, we're gonna go the replacement route. I also just added in, when we create a mechanical problem and we have a potentially definitive solution, mechanical support, even for patients in their 80s, may be considered as a bridge to intervention. Thanks so much.
Bruce, I have to ask, that's a great case. I have to ask, so when you had the ECMO in, did that cannula drainage affect your evoke placement at all?
Yeah, so we talked about, and I will say, it was, so according to Edwards, this is the first ever evoke done in a patient on ECMO. And it was a non-issue, you know,
Non-issue.
and you know, I don't remember if, you know, we have the whole perfusion team in there, if they were
Yeah, I mean,
maybe
do you
turning the
turn the
flows down.
flows?
Yeah, they were
Yeah.
probably adjusting the
Okay.
flows. But, you know, I was concerned, you know, was the cannula going to be in our way? Whether, you know, but obviously, thankfully, we had obviously large sizing IVC, so that was a non-issue. And
So how did you manage the flows during the deployment? Did you turn them down or turn
they
leave 'em up?
they did turn down the flows.
They turned down the flows during the leaflet capture, or how?
So yes, yeah.
Okay.
Yep.
I think this is
I can't be more specific. We had the whole perfusion team there, but I'm like, guys, do your thing. And they're like, okay,
what was
we're
the
going to turn
time
down
course
the
on the
flows.
ECMO afterwards? How long did it take to decannulate?
Like with 2 days. I think we did the valve on the Friday, and he was taken off ECMO on the Monday.
Were you concerned about your valve sizing now that the loading conditions were so different relative to the CT when they were?
So the only thing I would say is
Long registry.
the CT had been done a few weeks prior, and then we know that things got a little bit worse, but we went in quick, so we knew there was a difference, but we didn't think it was going to be dramatic enough. The reality was it was sizing for a 56 before. We resized in the room on echo. Everything looked, you know, dimension-wise similar, and we were comfortable with that.
I think one of the things as you said it earlier, people think tricuspid, there is no salvage because all the trial data shows only quality of life benefit, but we obviously did not include these patients. I would say at our center, we'll have a very tough time, putting ECMO in an 85-year-old, like to convince our ECMO team, even if we have a solution, unless it's AS, because everybody knows you relieve AS for tricuspid. So I think this is a great case in that way that you can resolve this, but this is the education that's needed, I think.
I think that that's a very practical issue, and it's going to take a while for that education to become more widespread. My center is very much the same way. What do you think about an Impella RP in these types of circumstances?
I think its issue is the TR. Question is, will Impella RP do anything with the TR when you have RV failure, TR?
Yeah, I mean, you're just temporary. You're trying to provide a little bit more forward flow.
It's just that we had
in
a
the
case
situation.
where it was not a Hail Mary, but patient had other issues and ultimately ended up dying. And the question was, what are we doing with tricuspid? No, tricuspid is only for quality of life. Why are we doing this as an inpatient? So all of these questions came up. And I think that's where the ECMO team will also come up with these questions. So I think as we do more of this, we need more education that actually there could be acute interventions that may help these patients as we go forward.
Right. I also just think, and I know, there's an argument to be made both ways here, but I think this is iatrogenic. And I think when it's iatrogenic and they're 85 years old and you already own that patient, if the administration is pushing back, you got to say, I do stuff and I got to be able to correct it, and I have a reasonable solution here. Very different than somebody comes in who's been failing for 85 years old and in a home and all that stuff. This is something that we did, and we got to fix it. And even if the data isn't perfect, reasonable.
Yeah,
thinking.
this is not a data-driven decision. We created a problem, we have a solution, and we're going to move forward and take care of the patient. That's our approach.
And I mean, we look at ECMO as a bridge to something. As long as it's a bridge to something, it's okay. If it's a bridge to nowhere, we just don't do it. But I did wonder about, with the flows, that maybe you'd want to turn the flows up so you would decrease the volume in the heart as you're doing your leaflet capture. It's just a thought. Yeah, maybe it would help you because you essentially dry the heart out. The valve gets a little smaller, and maybe it'd be a little bit easier to capture.
I mean, it was in the end of the day, it was just pretty much a non-issue. I mean, the evokes. I mean, they're not really technically challenging implants. It's really just the imaging, and just making sure you got your leaflets and if everything's falling on. It's pretty quick. Thanks.
Great case. Next up, we have Dr. Kostas Voudris.
Hi, good morning, everyone. Paul, thank you for the invitation again for this year. So it's a TAVR Hail Mary case, and to Kashish's point, I really tried not to make it a unicorn this year, so I hope you enjoy it. So it's a 79-year-old male, history of non-obstructive CAD, some heart failure with preserved EF, peripheral arterial disease, left endarterectomy, hypertension, dyslipidemia, DVT, COPD, anemia, came in with shortness of breath, heart failure exacerbation, your typical admission, pretty much Vmax 4.3, mean gradient 53, valve area 0.94, dimensional index of 0.20, normal EF, mild MR, trace TR, pretty much your best D1 candidate you can get, and at this point would not have made CVI if it was just this. So we're getting a CT standard protocol, a nice area, 611, calcium score 2,700. So kind of meeting all criteria, STJ classification, but nothing really surprising here. And that's what you get here for your peripheral access. So severely diseased, both left and right, femorals and iliacs. We did have a conversation with our vascular team whether they can do a little cut down and kind of bypass the calcification in the CFA, but the real concern is that the SFA is so diseased that if they were to do any of these things, that SFA would close off, and then it would be a really complex case for them to try to salvage the right periphery. So we started looking at what else can we do. So first thing, transcaval. So severe circumferential calcification of the infrarenal abdominal aorta. There's literally no spot. I put only 2 pictures of it. If you look at it, it's pretty much a circumferential calcium. There's nowhere to stick safely. Our optimal secondary access is usually carotid. So if we can get a carotid, life is easy. So right carotid, I don't think anyone has any interest. It's 4.2 millimeters. We barely feed a 13 friends of that area, and left carotid already has a atherectomy, so minimum excitement in getting in there. How about subclavian? Nothing there either. So what do you do? Any thoughts?
Yeah, I agree.
You go to the left carotid enterectomy?
Yeah, absolutely agree.
Yeah. Yeah.
Yeah, I mean, but to your point though, I mean, we go through like patches in the femoral all the time as well. Like, I mean, this is totally doable.
Let's say the vascular specialist says no to that. What's your next choice? Is anybody still doing transcaval?
Minimal.
I haven't done one in 7 years.
That's another good point. I mean, just that area of calcium there, you know, you could probably just do that as a prep.
How
Well, our
often are people
concern-
using shockwave to get access for TAVR? Are you guys using it much?
Very commonly for us.
Very
like,
commonly?
2 years ago,
like-
we did one alternate access case in the whole year. Was
Is that
everything
right?
else
Because of shockwave.
because of shockwave.
That's impressive. Bruce, are you using a lot of shockwave?
And we were. And then we had a couple of not great cases, which was probably my fault and probably a case selection issue. You know, as I say, you can't shockwave a 4 millimeter vessel and make it a 6 millimeter vessel. But once we took off with carotid, we kind of never looked back. And for us, carotid has just been the way to go.
I have to agree. With carotid, it's been our go-to. Mark?
Yeah, it has not become our go-to. We invested a little bit in Percax. Go ahead, shoot me now, but we did. So it slowed down our carotid uptick in using carotid, but we use a lot of shockwave. If there's a soft spot to enter the common femoral, and we think we can close at the end of the case, obviously a lot of other concerns, but we do use a lot of shockwave.
Even if it's bifurcation, like iliac, orthoiliac bifurcation?
Yeah, even then, however, we'll have a backup plan, and you know, the process gets slowed down the more people you consult, but we'll engage our vascular guys at that point and say, what's our plan if this were to go sideways?
Well, Paul knows that also. We engage with our vascular team a lot for the peripheral. We don't do a lot of the peripheral work. They're usually very hesitant to touch orthoiliacs. Those bifurcations, their concern is always like, we dissect, then it becomes a bigger problem. If it's a pure like iliac issue, like they're more open to the idea, but and also they do all our carotid, so.
I think it's like anything else. When you do more, you get more comfortable. Like our vascular, you know, we didn't actually involve them with all of that. But I like the E-sheath. Like, you know, if you can get the E-sheath across, then the game is done. I think we use dilators, propofol, you know, a lot of all those things. Yeah. But your access has to be good. Like the femoral access has to be good. Otherwise, it's a mess.
What was that, Harsh? The Viper slide. Yeah.
We
Is
use
it a routine thing
propofol.
you do?
Yeah. Yeah. Everywhere. Everywhere.
And then given dimensions of this case, actually, you can consider a 35 millimeter Navitor. So, it goes through a 15 French integrated system.
True, we don't have a Navitor active.
We don't have
case,
Navitor,
but it's a good.
All right,
So-
Kashish.
Anyway, so long discussion with vascular. They're not excited with anything. So this is what we did. So we did direct aortic. So our surgeons are really confident and comfortable doing that. So direct aortic, and we put an ardoid straight into teeth, and we're bringing our valve directly pre-mounted. I don't know if you notice anything weird about this valve, but see it here. Our balloon is ventricularly displaced. So now what? Any
And
thoughts?
you thought this is an easy direct aortic case.
Right? Access is not a problem anymore. So, yeah. So what happened is, if you ask my opinion, what I think was happening is most likely as the surgeon was pushing the valve through the certitude, they were holding a little bit more tightly than what they needed to, and the balloon just slided off the valve.
Are you sure that's not a poorly prepped?
Yes, because we
Valve.
actually floored it.
No,
we
there's
floored.
no reason that I just did a direct
Yeah.
aortic like 2 weeks ago. Don't shoot me. That should not happen.
So we always pre-floor them. So we floor them before we enter them in the certitude. It's very simple, because actually when they load the valve on the balloon, they kind of guess also there's no clear marker. So you put it under floor, kind of like what you do with your Evolute. You make sure that there is that your balloon is where it needs to be, and then you put it in the certitude. So it's not.
Do others fluoro their Sapiens
Well, just
Only
if
for
they're
the-
prepped on the balloon.
on the balloon?
Yeah. So
Even
like
then,
for
I don't-
mitral valve and valves, we do prep
Okay.
on the
Yeah.
balloon with the dry seal. But okay, so what now? Okay, so balloon's in the wrong place.
Take it out. Put another one in.
Take it out.
You have our certitude is 21 French, so it should come out.
You have pledgets there, so you just have to cinch them down, and then you still keep your Safari in and re-go.
I was actually thinking if you pull the system back, maybe the valve will slide back onto the balloon.
Same surgeon's hands.
Hemal?
Will this cross the valve is kind of my question.
Yeah,
mean,
it may cross
well,
the
I'll
valve,
show
but
you
then,
in a-
what part of the balloon are you going to
Just
deploy it on?
saying, you could partially inflate this, okay? All hope may not be lost here. And I mean, you may be able to get it to sit in the annular plane, prop open leaflets, and get it to sit there. And yes, you'll have to come down, come back up, and then inflate again. But it is, theoretically possible if this is really the only bailout that you're going to have. If your surgeon's like, there's no way that I could take this out without deploying it. But that would be a potential solution.
Yes.
Yeah, the valve's okay. It's a good line of thinking. The valve's fine. The balloon slipping off is just basically really the issue here. So I think the valve is competent. That's not going to be a problem. The valve performance is going to be fine. Question is kind of okay, is the surgeon willing to take this thing out at this point? Because I agree with Kashish. That's number one. But if not, I don't think that all hope is lost. I think you can actually get this to sit.
Looks like you went right carotid. Is that right?
No, it's actually.
This is
it
direct aortic.
It's direct aortic.
Oh, director. Sorry.
Yeah, sorry,
Okay.
direct aortic.
Okay.
So one thing that you have to be careful about is I believe I've looked at so many CTs now at CVI. I think there was a lot of STJ calcium. So now you're exposing that balloon And so I've had
Oh,
a
yeah.
situation like this where, just like you said, okay, let's deploy and it should be okay. And then you rupture the balloon. You have now you have a real
Now you
big
have a real problem. Yeah.
That's a great. That's a great.
It's
Well,
a
you have
great
too much of your
point.
balloon exposed to the elements.
Yeah, that's a
Yes.
good point.
The size actually of your STJs were higher than like your balloon size. So we're even like if you measured inside the calcification, so we're pretty comfortable that you can run away.
How's your
with,
patient doing right now with
Very
half that
stable.
valve?
It's general anesthesia, so patient is stable, everything's good. So we have a brief chat with surgery. They're like, yeah, we're not really thrilled about taking everything out and restarting it. So we thought we can do it.
What's the difference in the hole with that valve and that certitude sheath? Is it 1-to-1? Like, why?
The
It's about-
certitude is
yeah.
21 French.
Yeah,
That's
it's
why
at
21
it's
French.
actually it's not hard to get it out.
Dude, this is great. This is phenomenal.
So-
this is exactly what I thought would happen.
This is going to be your longest 30 seconds of your life. So it takes.
That's amazing.
So
So,
what
No,
we
I'm
do-
glad I like
Hemal was
envisioned. I
enjoying it.
envisioned
So,
this in my head, and now you're showing it.
So
This
what
is
we
this
do
great.
is-
this is clearly this is a new double tap.
Yep.
Right? So we throw around double tap like it's going out of style, but this is double tap on steroids.
So quickly, what we do is we rapid pace, and that's we tell anesthesia it's going to be a long pacing. Just bear with us.
So hold on a second. So you planned it. You planned.
Yes,
doing
this is a plan.
yeah.
So you talk to your team. It's going to be a long pacing. You absolutely don't turn off the pacer. There's no like until you hear like stop, you don't do anything. Deep breaths. We start deeper. We know that once the balloon reaches its point of pretty much expanding, we'll start sliding down even more. It's going to push the valve
I mean,
out.
I would have implanted deeper than that, but yeah, I mean, this is good.
That's brilliant. You caught the inflow as you inflated beneath,
Exactly.
and you pulled up. So how easy or hard was it to pull the balloon through
So
after it caught the inflow?
that's actually the biggest concern. So we deflated. I actually waited for at least 10, 15 seconds. I was like, I know it's going to be a long pacing. It's not my point, but my fear is that that balloon needs to be off completely, like completely
Agreed.
deflated.
And you know, honestly, like
completely,
I would have taken even more time. You did. I probably would have washed it out with saline a couple of times before I, kind of jacked it back like that. But
Exactly. And
you
then
know, that's
slowly
great.
pull back, kind of get the feeling like if I get a lot of resistance, I wasn't pulling. It was more like slow movement, stable, and you see it slowly coming in, get it close to where we want it to be, and give it a second tap.
Your pig in the non-coronary cusp at the very end looks below the valve. Was there paravalvular leak?
Beautiful question. So, what do you guys think?
fantastic.
I think, but you have to be lucky in these cases, right?
True.
The valve did
So-
not embolize because you have this high risk PAD patient. If the valve embolized, then you're in a bigger fix.
Well, the
right?
truth is the chest is open. So what they'll do is they convert it to open heart.
So maybe that was a discussion. That
Exactly.
if this
so
happens,
we knew that
don't
the
just open
bailout
the
is
patient.
not going to be as hard as. But having said that, this could have happened like you load your balloon on your transfemoral system and then it ends up being like more ventricular.
Did you think about just deploying this thing in the aorta and then coming in with another properly loaded? I'm just wondering.
We're actually,
like, I mean, that would be like kind of another kind of like an insurance policy if you wanted to do it that way, because then you could have fiddled with your ballooning and like just deployed it in the aorta, not risk like the embolization covering the coronaries, et cetera.
We felt that if you start deep, take your time, like do
Oh,
like
I
a
agree
long
with
pace.
you.
Like we
Yeah.
really felt that this valve can still be deployed and it can be deployed safely. It's just start deep, take your time, make sure you deflate the balloon, you continue pacing. It's under GA, so you're not on the clock for like 20, 30 seconds. Like we pace for 45 seconds. If we pace for like a minute, it's fine. Like we'll recover this patient and just like take the time, do it the right way. And like we really felt that this valve can be deployed.
Yeah, but I do wonder if, and it's the patient anatomy that's working in your favor. If you
Yeah,
were to do
100%.
this 10 times, I don't know how many.
No,
for
and
them to
if
focus.
it wasn't a heavily calcified, if you're adding those like plus 2, 3, 4 cc's, we knew that like, and then your valve starts for shortening, it would never be a.
Yeah, and then the
a
other
salvageable.
technical aspect of this is like I almost wonder if like not going all the way up on the balloon would have been an even like more stable way of doing this. Like not flaring it out all the way, because then the balloon has much more power, right? Like the balloon is going to slip ventricularly and act like a Jimmy force up the vector, towards the aorta. So
My
maybe
fear
I
is,
would have, just thinking about this, I would have maybe recommended that we deploy like 75%, deflate, walk the balloon up, and then pound it out.
Yeah, my fear was like, yeah.
Yeah, I could see there's a little bit of catch there as you were coming up. Yeah. Did the valve move up at all?
No, actually.
When you were pulling on the balloon?
No.
Nothing?
Yeah, and that's why we actually inflated all the way.
feel
I was like, I
feel
want to
like
be
we
sure
all
I
need
have
to
a
see
good
this
anchor.
again. Can you go back one?
Yeah.
I just think, we have even pulled it out in the 16 French E-sheath, so I think maybe it was worth a try to see if it will come back into the sheath first. Again, this is a case that went well, but it had a lot of, as Hemal said, you could have watermelon seed here too.
I'm like, at this point, you can tell, like, I knew I had a good anchoring on that, on the non-coronary clasp. So
Yeah, it's interesting. See, the valve looks below the pigtail here. And then see now it's a little bit higher. It's like at the level of the pigtail.
It continues to foreshorten on the
Yeah.
second tap.
Exactly. I think that's what it is. It foreshortened on the second tap and it rose up just a touch, but there's no issue with the STJs, huh?
Which proves Hemel's point that you didn't fully expand the skirt.
Which
Because
also
if it
makes-
continues to foreshorten,
Yeah.
your second inflation
Correct.
it further expanded it.
But
right?
there is a reason why.
Yeah,
right?
and that balloon, I mean, look at where we are here,
Exactly.
Mark. Like, I mean, that balloon is not going to be maximally expanding anything to that point.
No.
Because you're
That's just the
expanding at the
shoulder.
shoulder. So the shoulder is what pretty much opens up after some point, which is why I wanted to give it all of it. So I knew at least I have a good anchor.
Right,
as a
and
starting
you
point.
see when you're pulling it back, it doesn't move relative to the
No.
pigtail. This is exactly what you wanted to do, Hemel.
The reality is, like,
He did everything that I envisioned in my head, so thank you. That was
Harsh?
fantastic.
Yeah. They didn't want to pull it through the aortotomy.
Yeah.
These come out rough, and so I could see the surgeon's point
Yeah.
where now you had a nice hole, and now you're just gonna have a tear.
Yeah, and I don't think that this aorta is probably the friendliest aorta looking at the
Yeah,
rest
but
of
this
the
is
peripheral vasculature.
certitude is 21 French though. This is not 16 French, so it's bigger than your regular sheath.
why
It's
not
pretty.
just-
It's like easy to push these valves through 21 French.
So
Well, because you could dislodge you bring the balloon in, and then you dislodge the valve, and now you have an embolized, unexpanded valve.
That's still a very rough exposed edge.
So usually, at least when my vascular surgeons tell me every time we do carotid, it's like certitude, they're like, it injures the vessel a lot. So they're like, it's not your soft 21 dry seal that's like it goes in smoothly. They always ask they're like, can I put a dry seal? Or it's not your friendliest sheath. And I'll be honest with you, I don't repair vessels, so it's not, but they're always bringing up that, like we put propofol, we do the same, Viper Glide, like, bathe it doesn't matter. They're always complaining that it changes how their hole looks, it changes how the vessel behaves when they try to repair it, and they're not very thrilled.
And I maintain, if you were to try to pull that out of the aorta, just to start over, which is what I said, by the way, just thinking after seeing this case, I'd genuinely be worried that you just embolize this valve
Could
like
very
a stent
easily.
off a balloon.
Well, that's
So
what I
the
was
idea is
wondering,
like
if you abut it against the sheath, would it actually just slide back over the balloon?
Right.
Because it slid off the balloon
then go
going
back
in. You know.
So I'll be honest with you, I don't even know how much force it takes to actually move a valve over the balloon
So what do you
while
think
going
happened?
through a sheath.
So has anybody brought an S3 through a certitude back in?
I've never
Nobody
had
Brought
has?
it back
Have
through a
not.
16 French once or twice, and you basically it comes into the sheath, and then you have to pull the whole thing back out, and then put a sheath back in, a new
The
sheath.
entirety of the valve cage is in the sheath.
Yeah, you just put it on the. You just need to bring it inside.
Exactly.
But yes, the hole will be bigger when it comes out because you are in the expanded part of the sheath. So then you put a dry seal after that. I think it's Harsh.
Talking about the E sheath or the certitude?
the sheath.
Yeah, the E sheath for sure.
Yeah, the E-sheath, you can bring it back in. I think the certitude is just, it's such a rigid structure. I don't think.
What do you think happened? Who are you blaming?
I'm actually not blaming anyone. So to tell you the honest truth, I don't know what happened. What I do know is that when you put it under fluoro, like that valve looks perfect.
I guess one thing to learn from this case is maybe fluoro as you're entering the certitude sheath, because you would probably see it slip off as you're advancing it. That's one thing we can all take away from this.
So you do have to fluoro because you had to advance the everything to then de-air at a certain point. So you did fluoro within the sheath.
Yeah.
So it would be an interesting,
After a
but you're so
point,
focused
power up.
on
No,
this
yeah.
aortotic.
Yeah, you're not.
There's so much going on. You got 3 sets of hands. And I mean, this is a case. I mean, last time I did transaortic was 2 weeks ago, but before then it was like 5, 7, probably.
I blame
more.
the Edwards rep.
I do too, because they got to crimp this balloon. They got to crimp it on the balloon.
Well,
So I would blame
check,
him if
and I
it's
think maybe the
exactly.
learning issue is that there should be another fluoro check just before you exit the certitude sheath.
Yeah.
You know, because once you exit, then you've exited.
All right.
Great case, Kashish. Thank you.
Of course, I'll skip the rest. It's
Oh.
pretty much no PVL, no gradients were 8, like went home a day or two. So double tap, a variation of double tap is an option. Just keep it in mind.
Extraordinary double tap.
Your calcium
Thank you.
score was like 2,700.
Yeah.
That helps.
Yeah, I mean everything else like gradients, all this stuff. But thank you.
Thank you. Well, this is another fill-in, and it's kind of a show me. So all right. So this is a 64-year-old woman. She had evidence of right heart failure, and she had AFib with an EF of 65, and her TR is graded as torrential. Here's her echo. So in the right side is almost the same size as the left side. That's not always good. Her TAPSE was not too bad, but she had clear evidence of RV issues. And then here's her some inflow views. So I have to admit, this was not done at our center. I was helping to proctor this case, and so some of these images are a little bit challenging, but you can see that there's a lot of TR, and excuse the color flow there. But here's what it is. All right. So enthusiasm for TR?
No.
No. Everybody's shaking their heads. I know we're almost at time here, so I'll just show you. Gaps are really large. Really didn't want to do anything. So the perimeter was 190. So too big for evoke? Yeah. So what do we do here? Thoughts?
You got a couple of different clinical trial options you could consider here. So, I mean, if you did have access to TriCav1, this would be one potential solution. So for people that are unfamiliar, 2 valves, caval valves, superior vena cava, inferior vena cava systems built for that. It does not eliminate TR, but it eliminates the systemic manifestations, conceivably of the TR. Cree valve would be another potential solution in this particular patient. SVC stented with a metal arm that has like a spacer valve kind of attached to it. Those would be 2 potential solutions here.
Were they as optimized as they could be? Because the only thing we could do is pop in a Foley and just start giving them huge doses of IV Lasix and see if you could get them down a little bit.
So the RA pressure is like 12. I mean, it's okay. It's not great.
Yeah.
Well, I'll just show you what we did. Again, this is not at my center, but this is a new solution.
I've seen this thing.
Fun.
This is really cool.
Yeah, this is called TriPair. So many of you may remember Forma. Forma was this kind of spacer technology that Edwards had many years ago. There were some limitations to that technology, but this is a newer technology. This is called TriPair, and this is a system in which it anchors in the right atrium. It has this inflatable balloon in the middle that you can inflate and act as a spacer such that the leaflets can coapt on top of the balloon. And this is a nice direct visualization of how it works in a benchtop model. And this is a video. And the nice thing is that it can be done IJ or femoral, either way. There is a wire, which is kind of silly. I think the wire does nothing, but If you just watch this video, it's pretty straightforward. The key is that it's reversible all the way up in time until you decouple the system from the delivery catheter, and it anchors in the right atrium, which I think we still have a lot to learn. But you can see here, this is how it works, and it self-centers on the tricuspid valve, and then you inflate it there. So it's kind of an interesting system, and we did it in this case, and this is the result.
It's one
is
size fits
quite
all, or you
remarkable.
have to, there's different.
One size fits all.
One size fits all.
Yeah, they're coming out with larger sizes, but it's actually pretty neat. So-
What's your gradient?
No gradient, like 1 or 2. Yeah,
If you had a little bit more TR, could you tear through the system and complete the job?
I think so. I actually think, and we actually talked to the Crevalve folks about this, is that in some of these cases about tearing around to create a frame for the Crevalve.
Yeah.
You can imagine tearing around this and creating a frame for the balloon.
Makes sense.
Yeah. So I think that's a little bit down the road, maybe next CVI, but
Or even like a Tootsie Roll option if this
Tootsie
is.
Roll, that's right. Yeah, or Arctic, is the other one that Jamie McCabe was putting out there. Arctic with clips and then a Sapien down the middle.
What's your anticoagulation full?
Yeah, so it's actually just antiplatelet because it's not considered a valve. It's nitinol frame, so it's antiplatelet, not anticoagulant. So,
And what size sheath is that?
that's a good question. I believe it's a 24. I believe, and it's a 24 sheath, but the steerable is like 14. It's a pretty steerable.
This is EFS. Or
EFS
not.
right now. Yep. So this is a case in France that I went and did a couple months ago, and we're starting a global study. So coming to all of us hopefully soon. So
How is deployment challenging?
it's super easy. It's a single curve flex, and it's honestly each of these take 15 to 20 minutes because it's just a single curve flex, positioning, inflation.
Do you need to,
No
are
leaflet
there different
capture.
sizes based on the right atrium?
Yes. Yep. So there are 3 different sizes for the atrial frames, but right now it's mainly one size. So very safe, as a lot of right-sided interventions are, and so I think it's something that may be coming. We'll see. Hopefully, it doesn't go down the same path as Forma, but it's a novel approach.
I
So.
was about to say, like, 4 months, they did about 30, 40 cases, and overall, like, in follow-up, the results were just not as
Yeah.
good. I think that is that where the spacer technology kind of went away, but it's coming back.
Yeah, I mean, there's TriFlow, there's the Forma. I mean, Crevalve is technically a spacer, but it has a valve, so the different approaches that, I think are interesting how they feel. But to me, I still feel that we need something that holds the valve. I don't like technologies that don't hold the valve because I think if there's residual TR, there's a risk of recurrence, and I think Forma showed that. So
The
it's
other
not
issue
going to be
is-
my first choice, but I think if it's something for patients who can't have other technologies, it's one thing. The other thing about this is that it's retrievable even after full deployment. So that acute case, who showed the acute? Bruce, your case. So you could put this in, diuresis patient, and then bring it back in a couple weeks, take this out, and put the Evoke in. It has a retrieval mechanism.
That's what I was saying. A lot of other Crevalve, that's the issue. Like, once you
Yeah.
put it in, it's it. That's it.
Yeah.
You can't do anything else. If it's retrievable, it could be a month thing as well.
Is that right? Yeah. So it's it's kind of like your bridge. It can be a bridging technology. So, all right. Well, that closes this session. So then we're going to take a 30-minute break and come back for the last session of CVI. Thanks so much, everyone.